Good afternoon, everybody. Welcome to the 18th Annual Astute Clinician Lecture, and I also extend welcome to the folks who are watching this on videocast. My name is John Gallen, and I'm the director of the Clinical Center, and I have the honor of introducing today's speaker. Dr. Francis Collins regrets that he could not be here, but he sends wishes for a successful lecture and congratulations to Dr. Zarate. This lecture is part of the NIH Director's Wednesday afternoon lecture series, and it was established in 1998 through a gift by the late Robert W. Miller and his wife, Haruko. Mrs. Miller regrets that she's not able to attend today. The series honors a clinician scientist who has observed an unusual clinical occurrence, and by investigating it, has opened an important new avenue of research. And our speaker today is certainly a wonderful example of such. Dr. Carlos Zarate is the senior investigator and chief of the experimental and therapeutics branch and the section on neurobiology and treatment of mood and anxiety disorders of the National Institutes of Mental Health. He is also a clinical professor of psychiatry and behavioral sciences at the George Washington University and professor of psychiatry and behavioral sciences at Howard Medical School. His areas of expertise include biological and pharmacologic aspects of mood disorders in adults. His current research focuses on developing novel medications for treatment-resistant depression and bipolar disorder, as well as the study of biomarkers and neural correlates of treatment responses. Dr. Zarate earned his medical degree at the Faculty of Medicine from Catholic University at Cordoba in Argentina. After he finished his medical degree, he actually spent a year in cardiovascular internship, which we learned about during a lunch we had earlier. But then he started to pursue his advocation, which he's working on today. He moved to the Massachusetts Mental Health Center in Brockton Veterans Administration Medical Center to initiate his residency and training in psychiatry, and then completed a fellowship in clinical psychopharmacology at McLean Hospital located in Belmont, Mass. Dr. Zarate remained on staff at McLean Hospital as the director of the Bipolar and Psychotic Disorders Outpatient Services until 1998. From 1998 to 2000, he was the chief of the Bipolar and Psychotic Disorders branch at the University of Massachusetts Medical School, and in 2001, he joined the NIH Mental Health's Mood and Anxiety Disorders program in NIMH, and as a staff clinician, and he was tenured in 2009. He is a recipient of numerous awards, including the National Alliance for Research on Schizophrenia and Depression, and Independent Investigator Awards from 2005 to 2008. He received the Brain and Behavioral Research Foundation Award for Bipolar Mood Disorder Research in 2011, and the Mogens Show Bipolar Disorder Research Award in 2013, and the American Psychiatric Association's Simon Bolivar Award and the Ruth L. Kirstein's Mentoring Award in 2015. Dr. Zarate has also received the NIH Director's Award in 2007 and again in 2013, and his research has earned numerous patents for treatment of depression. He was a scientific advisor for the American Foundation of Suicide Prevention in 2014, and he currently serves as a member of the NIH Advisory Board for Clinical Research. He has numerous society memberships, including the Society of Biological Psychiatry, the International Society of Bipolar Disorders, and the American College of Neuropsychopharmacology. And he served as a member of the Mood Disorders Committee for the Diagnostic and Statistical Manual of Mental Disorders. DSM-5 from 2008 to 2013. So we're very excited that we have such a wonderful speaker to talk with us today, and the title of his talk is Relief from Severe Depression and Suicidal Ideation Within Hours, from Synapses to Symptoms. Please welcome and congratulate Dr. Zarate.
Thank you so much, John, for your kind introduction. It's truly an honor to be selected to give the Astute Clinician Lecture for this year. Clearly, our patients with mood disorders suffer tremendously. Although we have treatments for many, they are suboptimal. We see low remission rates, as I'll talk about. And the main thing is the lag of onset of action. Most of our treatments, antidepressants, take probably 8 to 10 weeks for full antidepressant effects. What we're talking about is shifting the paradigm to treatments that work in a few hours, hence the title, Relief from Severe Depression and Suicidal Ideation Within Hours, from Synapses to Symptoms. Okay, this is my disclosure. I'll talk about the off-label use of ketamine, which is the focus of our work. In terms of the outline of the presentation, I will review current concepts of depression, diagnosis, disability, morbidity, and mortality, the course of illness, current medications for depression, what are the neurosciences challenges in drug development, and some novel approaches in drug discovery and development that we are taking in terms of new paradigm, biomarker development, and a focus on glutamatergic modulators. I'll also review the next steps in ketamine research, its current use in clinical settings, development of ketamine-like drugs without its side effect profile, understanding ketamine's mechanism of action, and if there is more to the ketamine paradigm. Mood disorders consist of the major ones of major depression and bipolar disorder. We can summarize them as individuals who have disturbances of mood, behavior, circadian rhythms, and activity levels, which cause severe impairment in the ability to function. Mood disorders result not simply from low levels of serotonin and norepinephrine and other monoamine transmitters, but now are viewed as disorders that have significant disturbances of synapses and circuits. In terms of symptom domains, there are four. Here we describe three. The first, in major depression, we tend to see individuals with a negative affect or mood and behavior. We see depression, anxiety, irritability, and of course, self-injurious behavior or suicide attempts. Individuals who have bipolar disorder have the major depressive episode, but in addition, they have the polar manic episode. These individuals have increased energy levels, pressured speech, grandiosity, impulsivity, recklessness, and a significant decreased need to sleep. What they do have in common is they may also have the other domains, psychotic symptoms, delusions, hallucinations, or they may have cognitive symptoms as well. For example, distractibility, disorganization. Now, a single individual can have any mixture of symptoms. Here, this figure depicts an individual, the same person during the depressive state and during the manic state, sitting down, depressed, staring into the distance, preoccupied with inner thoughts. Whereas the same individual during the manic state is probably pacing back and forth, talking nonstop, dressed in multiple layers of clothing and carrying many items. Now, our mood disorders are associated with significant disability. In this study, a measure was derived called DALYs, or disability-adjusted life years, since the outcomes differ from disorder and disorder. We see the ranking of medical conditions from the top to the bottom of those that cause major disability. We can see at the top neuropsychiatric disorders, largely followed by cardiovascular, circulatory diseases, and neoplasms. In terms of neuropsychiatric disorders, we see that mental and behavioral disorders is the largest group here. And the greatest disability of the mental disorders probably is attributed to depression, psychosis, as examples. Depression is the leading cause of disability worldwide. And not only is there significant morbidity, but there's significant mortality. Here we see the mortality from major medical causes. Here's the peak between 1965 and 1995, and how we're doing over the years through discovery in terms of mechanism, pathophysiology, or for that matter, developing novel treatments. We can see, for example, all causes of leukemia. There's been a significant decrease in mortality, followed by 1 million deaths that have been averted for new treatments in heart disease, significant improvement in AIDS, and in stroke. That's not to say that we can't do much more work into improving the decrease in mortality from these illnesses. But what about our major mental disorders? What about suicide? We haven't made a single dent in the number of deaths for suicide. In fact, we see increases over time. And for that matter, if we believe that we're doing, one measure of how we're doing is by decreasing the prevalence of severe mental illnesses. We have not significantly decreased the prevalence of our severe mental illnesses. Now, this slide summarizes the course of illness, comorbidity, life impact, disability, and neurobiological insults, and is a matter and is a summary of what we know to date. Here represents the lifespan course of mental illness, an individual with bipolar disorder. In blue, you see major depressive episodes. In green, manic episodes. Usually one sees about 8 to 10 years from the first major depressive episode, which happened in late teens, until the first manic episode. It often takes about 8 to 10 years to receive the correct diagnosis, and individuals will have visited 3 to 4 different clinicians until the correct diagnosis is made. Way too long. Here we see the impact of each major depressive episode. We see significant disruption to personal, family, occupational, social life, and of course the risk of suicidal behavior. Compounding our mood disorders is the significant comorbidity. If you have major depressive disorder, it's estimated between 40 and 50% have another comorbid psychiatric disorder. If you have bipolar disorder, up to 90% of individuals may have a comorbid psychiatric disorder. 70% of the time they have 3 comorbid psychiatric disorders. And I'm not summarizing here the comorbid medical conditions. Naturally, it's estimated that an individual with bipolar disorder will have 9 major depressive episodes. Some will have a chronic, relentless course where they'll be chronically depressed. In this longitudinal study of nearly 200 patients that were followed for 13 years, they found that half of the time, 6.5 years, they spent having symptoms of the illness. 1/3 of the time was depression. So you can imagine having chronic depression. Each episode of depression also does cause insults to the brain. It's believed to be secondary to cortisol, stress, and perhaps glutamate. And we see regional reductions in brain volume, and at the cellular level, one might see a shriveling or atrophy of dendrites and neurons. In fact, here we see a reduction in the number of spine densities, and thus synapses and circuits are affected. And depending if you have your circuit, this is a bit simplistic, but if you have your circuits intact that have to do with normal sleep and cognition, that would be intact. Whereas if you have a disruption in other circuits, you might have the clinical picture of anhedonia, or for that matter, you might have suicidal ideation. So this is, has been mentioned, the Diagnostic Statistical Manual is a checklist of symptoms. It's not based on pathophysiology. It's based on a collection of symptoms that occur commonly and are frequent. It has its utility because it's a common language for describing psychopathology, but it doesn't have significant treatment implications. And here we can see that it's now considered that within major depressive disorder, we have hundreds of disorders, perhaps, with several with different etiologies. And you can see the tremendous overlap that exists with panic disorder, obsessive compulsive disorder, psychosis, bipolar disorder, and so forth. So no wonder it's very difficult to tease out the psychopathology. In order to have a greater understanding of psychopathology, some have argued, and it's referred now to the research domain criteria, or RDoC, that we have to pull out the more simpler elements. In this case, we could pull out anhedonia, suicidal ideation. We deconstruct the symptom, and at a simpler level, we look at what are the behaviors, what is the physiology, what are the circuits, what are the molecules and genes that are involved in that specific item that's under study. And that once we have a better understanding of the pathophysiology of these RDoC domains, we may be able to come up with better treatments. And I will provide 2 examples, anhedonia and suicide, later on in my talk. Now, here this talk is about developing the next generation of treatments that work in hours. Why do we need new treatments? If we have 30 to 40 antidepressants. When a brief history of the evolution of antidepressants, early on in most of our drug discovery in psychiatry has been by serendipity. One of the first drugs was iproniazid, used for the treatment of an antibiotic, and what was noticed that some individuals were dancing and were elated, and it became known later as an MAO inhibitor. MAO inhibitors were later developed based on the belief that serotonin and norepinephrine were the key neurotransmitters involved in effective antidepressant treatment. Then we had the generation of the tricyclic antidepressants, and later on we see that there had been a move to go into more selective targets, such as selective serotonin reuptake inhibitors, because the side effects were nasty and because they were overdose on tricyclics was highly lethal. Now, clinicians then started later on saying, well, perhaps these monoaminergic antidepressants are not as effective as the older antidepressants, and let's go back to the dual reuptake inhibitors, and now there's the tri-reuptake inhibitors. So there has been a movement back and forth. Bottom line is there has been no convincing evidence that any of these antidepressants are more effective than any of the other antidepressants. And this is a large outpatient study called the STAR-D, and they looked at 3,000 outpatients, and these are the remission rates. After the first trial, about 1/3 achieved remission. Remission means significant improvement, very few symptoms or no symptoms at all. But one can see with the following treatment trials a significant decrease in the remission rates over time. So we could do much better than that. In fact, it often takes 2 antidepressant trials or 6 months for half of the people to achieve remission. Way too long. We already talked about the consequences of delaying treatment, disruption to personal life, social life, family life, and the risk of suicide behavior. So these are areas we can target: higher remission rates, more rapidly acting antidepressants. Now, why have we not developed better drugs? And this is a summary, and this is probably a problem common to other medical illnesses. We have, this model has not been highly effective. It takes about 15 years to develop a drug, or between 4 and now recent estimates up to $11 billion. You put 10,000 compounds in a funnel and you come up with one drug. Now, the greatest success rates are anti-effective agents, about 25%, and so on and so forth. But you get to the bottom, CNS has the lowest success rate, 8%, and for psychiatry, it's even lower. Why the problems in developing new medication? Industry has tried very hard. Well, first of all, it's hard to model preclinically higher order brain function. The next problem is the limited ability to obtain biologically enriched subgroups. I already talked about how we have this heterogeneous group of disorders that are put together. And then finally, of course, the sheer complexity of brain disorders. So what are the goals of our research program? Is to develop novel and rapid active pharmacological therapeutics for patients with severe and treatment-resistant mood disorders. We start by identifying a target, in this case the glutamatergic system. We conduct double-blind proof of concept studies in drug-free patients, taking them off their medicines. We do that on our research unit. And we integrate this with multimodal imaging, obtaining biomarkers to obtain or predict response, and hopefully with the goal of improving treatments. Now, where do we start? Well, we talked about the limitations of monoamine antidepressants, but it's through the elegant work of Phil Skolnick that discovered that NMDA blockade leads to antidepressant effects in preclinical studies. And earlier work suggested that perhaps ketamine produces rapid antidepressant effects, but had not been really studied for many different reasons. And so we decided to take a broad approach in the last decade to focus on the glutamatergic system. Glutamatergic system here is the tripartite system. We have a presynaptic neuron, postsynaptic neuron, the glia. Glutamate is an excitatory amino acid, one of the most abundant in CNS, synthesized, stored in vesicles, and then released into the synaptic space. Very important for learning, plasticity, memory, and other functions. Now, there is no way of, there's reuptake mechanisms to regulate the amount of extracellular levels of glutamate, because high levels could be excitotoxic and has been reported to be associated with neurodegenerative diseases such as Parkinson's, Alzheimer's, so on and so forth. Now, many drugs were developed over the years for neurological conditions, and we took advantage of these drugs and have been systematically studying them over the past decade. There are a number of potential targets. One can go at the presynaptic vesicles, at the release mechanism. One can go at metabotropic receptors that regulate the release of glutamate, kind of like a thermostat. One can go at the excitatory amino acid transporter, incorporating greater amounts of glutamate, or at the postsynaptic level, NMDA and AMPA receptor, which most of the business is here at the NMDA receptor complex. Now, this is a more detailed summary of what are the compounds that are being studied. And before I mention that the sheer complexity of disorders and the problem in drug discovery, we've had over a dozen companies drop out of psychiatry, many out of neuroscience altogether. Now, through this body of work, we now have had people coming back into the business, and a number of compounds are being studied. At the metabotropic 2 receptor, we have positive allosteric modulators, the PAM, also negative allosteric modulators, antagonists. And at the mGluR5 metabotropic 5 receptor, these are co-localized with NMDA receptors and modulate its function. We have a number of compounds. NMDA receptor complex modulates, which will be the focus of my talk. AMPA potentiators, which unfortunately has been to this moment disappointing, at least in depression, and ways to enhance excitatory amino acid transporter. And then one can modulate the glycine, which is the co-agonist of the NMDA receptor complex. And so many different compounds are being looked at today. Well, what about the NMDA receptor complex? We have broad NMDA antagonists and more selective. I'm going to focus on our work with ketamine. Ketamine is an anesthetic agent used worldwide, particularly in emergency room settings for diagnostic treatment purposes, also used in children. Now, it is a derivative of PCP, 10 to 80 times less potent. It binds here. This is the NMDA inotropic receptor, the channel. We have sodium, calcium going through here. The PCP site, which causes the side effects, dissociative side effects you see with PCP. Ketamine binds to this channel. It closes the upper lip of the channel, thus impairing the function of the channel. And while you're receiving ketamine, only while you're receiving ketamine, a little bit after, you experience the following side effects: psychological, decreased awareness of the environment, sedation, vivid dreams, distractibility, and generally uncommunicative. There's also dissociative side effects, which are pseudo hallucinations, and one is temporarily disconnected from body senses, a distorted sense of time, sounds, and surroundings. And they're physiological, which is increased blood pressure, pulse, and ketamine's use has been reported to be associated with addiction. In terms of psychological addiction, no clear evidence of physical addiction. And generally, when it's used, it's in combination with other drugs. Here we study drugs that are ketamine that is at much lower doses than is abused out there. Ketamine has been around for 50 to 60 years. We know what to expect. The side effects in general are mild and moderate. Now, because of the side effect profile for ethical reasons, when we tested our concept, that is, proof of concept, if we target the NMDA receptor, would we bring about rapid antidepressant effects? It was important for ethical reasons to study individuals who had failed most things. And here you see a summary. Patients were on average 25 years ill, 50% were disabled, 90% were unemployed, 40% to 50% had comorbidity. They had failed on average 7 antidepressants, 60% have failed electroconvulsive therapy, arguably one of the most effective treatments for depression, and 50% had multiple suicide attempts. Now, in my clinic, in my practice, I would, generally reach a point where you've tried most things. What are you going to do? In the end, it ended up being making sure you weren't causing problems and side effects by combining different medications and giving the individual a sense of purpose, autonomy, and improving their quality of life. After this, it's much more difficult to obtain remission. Nevertheless, in our proof of concept study, a single infusion of ketamine, an MDA antagonist, brought about rapid antidepressant effects within hours. Here we see the depression scores. Higher indicates greater severity, time in minutes and days. In green, ketamine, and red, the control condition. We see rapid onset within a couple of hours with one infusion lasting a good part of the week. Towards the right, we see response rates to ketamine. And here in blue, we see response rates to our monoaminergic antidepressants, which is about 62 to 65% after daily treatment for 8 weeks in individuals who did not have treatment-resistant depression. Towards the left, we see response rates that are comparable to that of our standard treatments within 6 hours to 1 day in individuals who were as ill as I mentioned. So the first few patients we treated, we said, wow. But of course, you can always see one case of something. But when you see it, over and over again. Now, here it's important to emphasize that about 60% respond, 40% do not. And most of our work is now trying to figure out through biomarker who are the responders and non-responders. Now, this is one example of one of our patients, 53-year-old married man, 35-year history of severe refractory depression, many comorbidities. We talked about anxiety disorders, alcohol dependence, 10 previous episodes of major depression, family history of mood disorders. In 2006, had a suicide attempt, overdosing in nortriptyline, was admitted to NIMH, was severely depressed, had thoughts of stabbing himself or driving car off a cliff. And our patient participated in a study, one of the responders, and we found within few hours response, remission of symptoms, suicidal thinking was gone, and this lasted approximately 20 days with just one infusion. Now, very important to replicate studies, and as you know, very few studies are replicated today and age. We focused here on treatment-resistant bipolar depression. Here on this axis, depression, greater severity up, time in minutes and days. One infusion of ketamine led to significant antidepressant effects within 1 hour, lasting a good part of the week compared to the control condition. Towards the right is a replication study, and you can see essentially the same thing. Rapid onset of antidepressant effects in people with severe treatment-resistant depression lasting a good part of the week. Now, what is amazing from these two studies, and if you're correct, the previous study, is the similarities in the onset and offset, the time course of antidepressant effects, which speaks to perhaps a true biological effect here, in that we can probably understand to develop better treatments. Now, after 5 controlled studies we conducted, extramural NIMH conducted this larger 2-site study in patients with treatment-resistant depression, a control condition called midazolam, a benzodiazepine, and essentially found the same thing. Rapid onset within 1 day, earlier antidepressant effects within hours was not assessed, but lasting a good part of the week. Now, there are a number of replication studies. The American Psychiatric Association just published in American Journal of Psychiatry a review and meta-analysis and concluded ketamine does indeed have rapid antidepressant effects in treatment-resistant conditions. But we need to know more about the mechanism of action. Now, one of the limitations or concerns, well, you give one infusion, how do we keep people well? How do they stay well? And so a number of things have been tried, nothing large and controlled, some repeat open infusion studies. But here, Jazz Singh, who is my previous fellow, is now at Johnson & Johnson developing the ketamine program. And now they're in phase 3 studies. But in this early phase 2 studies, they found repeat doses of ketamine 2 times a week versus 3 times a week was just as effective. There was no difference and kept the scores down. So there is considerable interest in, they have received $300 million in funding to continue their phase 3 studies. Now, what are the next steps in ketamine research? Okay, as mentioned earlier, there are patents. It's been licensed by J&J. They're developing S-ketamine intranasally, and it has received, I think it's been the first in antidepressant history, a breakthrough therapy designation, meaning they can fast track through the regulatory process. And they are aiming for the end of 2017 to the beginning of 2018 to be in the market if all goes well. Now, there's off-label use of ketamine worldwide. Now, in New York alone, there's over a dozen clinics giving ketamine. As I mentioned, many companies dropped out. There are 12 companies who have jumped in specific in the area of glutamatergic modulators for depression. And there's probably over 40 NIMH grants and one research center examining different doses of ketamine. Now, what about developing ketamine-like drugs without these side effects? And that's work that we and others have undertaken. This is a summary of the studies. Here we talked about ketamine, memantine, Namenda used for Alzheimer's disease as an NMDA antagonist, use-dependent. We did a control study and didn't find significant antidepressant effects. We looked at AZD6765 and saw in the same design, one infusion saw brief and not robust antidepressant effects, but there was no evidence of dissociative side effects. Towards the left, we have studied RO256981. It's a tool compound I'll talk a little bit more about. Traxoprodil by Pfizer was tested. One infusion resulted in improvement within 5 days, and it lasted for a significant period of time. However, it was associated with dissociative side effects. We tested MK0657 and found some hints of antidepressant efficacy that was picked up by CERC 301, and they're doing multi-site studies in depression and suicide. Now, what about the glycine site? The serine we have found in animal models to predict antidepressant effects. The cycloserine is available, very costly. It's an antibiotic. And it seems to have antidepressant effects in treatment-resistant depression, but it takes quite a bit of time. Glix13 is a monoclonal antibody that serves as a glycine partial agonist. It has a 7-minute half-life, and preliminary studies suggest it might have rapid and prolonged antidepressant effects in humans. It was Norrex, the company, was recently bought by Allergan for something like $700 million to continue phase 3 studies. Now, what about other ways of modulating the glycine site, which you need a mandatory coagonist at the glycine site, which modulates this NMDA receptor complex with the hope of achieving rapid antidepressant effects, but without the dissociative side effects. One possibility is 4-chlorokynurene. 7-chlorokynurenic acid has for a long time been demonstrated to have antidepressant-like properties in assays of antidepressant efficacy. However, it does not cross the blood-brain barrier. So a prodrug was developed. It's incorporated into astrocytes and converted to 7-chlorokynurenic acid and serves as a glycine antagonist, thus producing a net decrease in the function of the NMDA receptor complex. We see here evidence that it doesn't cross the blood-brain barrier, whereas the prodrug does. In collaboration, University of Maryland, we collaborated with them, conducted these acute antidepressant studies and prolonged antidepressant effects with this compound. Towards the left, you see the forced swim test, where you have a rodent in a cylinder, where they're in water and they're struggling to swim. And we say that if they don't swim anymore, they've given up, and that's supposed to represent a model of despair, whereas if they continue to struggle, that signifies antidepressant efficacy. Here you can see a significant decrease with ketamine, as with other antidepressants produce that. This indicates antidepressant-like properties. 2 different doses of fluorochloroquine does show similar effects to ketamine. Towards the right, you look at the learned helplessness, escape failures. Once again, down indicates greater antidepressant efficacy. At 24 hours, you don't see this with many antidepressants, and especially 7 days later, you see this with ketamine in this fluorochloroquine at 25 mg/kg. So this drug has been studied in pain, in a pain model in healthy volunteers, and it was noted to give some well-being or euphoric effects, so we were interested in studying it, of course. Here, this is a double-blind placebo-controlled trial. It has already started, where we give several weeks of the drug versus placebo. We obtained 7-T-MRS as a in vivo measure of glutamate, and I'll talk about the importance of obtaining glutamate burst that appears to be important for rapid antidepressant effects. The majority of studies I mentioned to you, there is no measure of target engagement, and I think that's very important. Our work is to try to find surrogates of target engagement, so that if you actually find something, don't find something, you know that you were at the intended target and you actually tested your question. Okay, this is now moving on to biomarkers, a conceptual framework. I talked about the double-blind studies to obtain the therapeutic relevance of agents. Now, in terms of biomarkers, we take advantage of rapid acting agents. Here, ketamine, sleep deprivation, now neuromodulation, which we think produce rapid antidepressant effects. At baseline, we obtain biological measures with the goal of doing more efficient studies, but then we link the response, non-response to traditional scales with this neurobiological measure to obtain a biologically enriched subgroup. And I'll give an example where we use family history of alcoholism as an enriched subgroup to predict better response to ketamine, and I'll talk a little bit more about that. We also obtain multimodal measures throughout the trial, and I'll give an example, to identify the neurobiology of response. Rather than the illness, we're focused on neurobiology response, and since the effects of ketamine were off, the neurobiology of the relapse process within the same individual. So in terms of the obtaining of biologically enriched subgroups, most of our biomarkers are obtained post hoc. Very rarely, if ever, are they tested prior to randomization or used prior randomization. Now, we subsequently noted clinically that our patients who had a family history of alcoholism seem to have better response. We have shown clearly in our studies, as I mentioned, over 3 independent studies that family history of alcoholism predicts better response, and this has been independently replicated outside of our center. Now, if you look at the history of alcoholism and response based on family history, you see in general that individuals who have a family history of alcoholism compared to not will have a more distressing side effects and less intoxicating effects in some way. Ketamine, similar to alcohol, is also an NMDA antagonist. Both are. So these centers looked at ketamine in terms of family history and did find that if you have a family history of alcoholism, you're a healthy volunteer, when you're exposed to ketamine, you see attenuated side effects in terms of psychomimetic dissociative side effects. So it does give some hint that there possibly could be some subgrouping. This is added that there have been some study suggestion that there's genetic variation in NMDA receptor subtype, which increases vulnerability to alcoholism. So we looked at our patients who had been treated with ketamine based on family history. Here you see in the darker color, family history positive, family history negative. Down means great improvement, significant antidepressant effects, and less dysphoria to the effects of ketamine. We've seen this in 2 other studies, and this has also been replicated independently. Now, using this information, the problem is that you ask about family history, and it's not really that reliable. And so what we're trying to do is match family history with psychophysiological measures, or for that matter, glutamate changes to alcohol infusion to obtain more biologically enriched subgroups. Here in this study, individuals who are depressed, drug-free, receive 2 infusions of alcohol. We keep it at steady state. You obtain psychophysiological measures in the first. In the second, they are receiving a 7T MRS scan looking at glutamate changes. And then a few days later, they receive the ketamine infusion. Then we look at outcome. Very preliminary data. This is by Nishu Evans. Here we see alcohol, the changes, what is pre-change during the alcohol infusion. Post-alcohol infusion, we see changes in networks very similar to ketamine, both an MD antagonist, but we see in general a larger reduction in functional connectivity in individuals, in a patient with treated with ketamine compared to when they received alcohol infusion. So very preliminary, larger sample size will hopefully permit us to identify subgroups that respond or not. This is one example of approach that we're taking. In terms of RDoC, getting back at anhedonia, the inability to experience pleasure from activities usually found enjoyable. We talked about how we see anhedonia across every disorder, most disorders, and there is no treatment, very common symptom after antidepressant treatment. And the goal is to study different levels. Here we see from our previous study, as I mentioned, 1 infusion of ketamine leads to rapid antidepressant effects within 1 hour, lasting a good part of a week. What about anhedonia? So hedonic tone is disrupted in patients with depression. When we use the Snaith-Hamilton pleasure scale, look specifically at that, you see significant improvements in hedonic tone with 1 infusion of ketamine lasting up to 2 weeks. Now, in the RDoC concept or model, it's important to link with one of these other dimensions, and so we looked at circuits. So you map the biology, you map the symptom or that you're interested to the biology. Towards the left, we look at ventral stratum, which is involved in reward processing, and we see using PET, positron emission tomography, FDG, fluorodeoxyglucose. We see a significant correlation between increases in cerebral metabolic rate of glucose, 85% of which is the glutamate signal, and in improvements in the hedonic drive. If you look at the areas affected, it's ventral stratum for both depression and hedonic tone. But in factor analysis, you see that depression and hedonic tone separate. And in fact, when you do that, you see that the increases in cerebral metabolic glucose rate specifically for improvements in anhedonia is in dorsal cingulate cortex. Different components such as anticipation and motivation of reward. Now, in terms of the third step is understand the mechanism of ketamine action, very complex, ambitious study where 1 individual before treatments receives these different modalities. Just to summarize, we found that slow wave activity, putative marker synaptic plasticity is associated with response to ketamine. And I will talk more about MEG analysis, but the goal is to start trying to fit these bins everywhere from complex symptoms to information on circuits. Now, how might ketamine work? Well, this elegant study by Bida Mogadam in 1997 showed that extracellular levels of glutamate increase with ketamine, and coincidentally in the same time scale as you see in patients, which is quite interesting. So we hypothesized that that there is a net increase in glutamate, which results in an increased AMPA activation, and that the AMPA activation is key to the antidepressant effects of ketamine. So in a preclinical study led by Eddie Mang, we used the immobility study. Remember, decrease suggests antidepressant-like properties. An AMPA antagonist, NBQX, does not decrease immobility, does not have antidepressant effects. And when you pre-treat, give this AMPA blocker prior to ketamine, you abolish the antidepressant-like properties of ketamine, suggesting AMPA throughput is important. Go into the tool compound RO256981, which is select an R2B antagonist, the same thing. An AMPA antagonist blocks the antidepressant effects of this NR2B antagonist, suggesting AMPA throughput is important. This has led others, Ron Newman particularly, to put this model of how ketamine might work, and it has to do with glutamate burst. Ketamine is an NMDA antagonist, as well as scopolamine at the muscarinic receptor. Both produce rapid antidepressant effects. They block the respective receptors on GABA interneurons, produces glutamate burst, which increases AMPA activation, eventually calcium release, increases in BDNF, mTOR activation, and increase in spines within hours has been demonstrated preclinically, thus restoring normal homeostatic mechanisms of plasticity and function of circuits. At least that's the theory. One of the studies we'll start in the second quarter next year will be to give a drug that blocks AMPA receptors, see we can abolish the antidepressant effects of ketamine. This to show you that new tools are very important. In this recent study, looking at 7T, we're able to find and measure very nicely the glutamate peak, and it's quite crucial because imaging technologies with lower strength are not able to clearly delineate the glutamate peak. This study is near completion for patients with severe depression, where individuals will obtain these multimodal assessments, baseline, and throughout the trial, something like 5 scans, multiple sleep studies to get precisely at the neurobiology response and relapse process. One example of recent data, very preliminary, focusing not on task but on resting state, which involves spontaneous fluctuations between different regions that communicate with each other at the same time. You can see the different regions here in this matrix. Areas with a brighter color, a warmer color, means higher correlations or coupling between regions. And lower colors indicates anti-coupling or lower correlation between these different regions. These networks have been identified, default mode network, a dorsal attention network, so on and so forth. These can be measured or examined with fMRI and MEG. In this study, looking at individuals who received 5 scans, to the bottom you see this is the matrix and the correlation. We see baseline after a couple days of the ketamine infusion and way out 10 days later. Here you would expect response and non-response, and here you would expect most individuals to relapse. So in that sense, we'll be able, with fMRI, data not available yet, and MEG, to look at the changes over time. And so it will give us a better measure of what the neurobiology of the response in the relapse process is. Other data looking at intrinsic connectivity. Here we see that individuals with major depressive disorder have decreased connectivity in subgenual anterior cingulate cortex compared to healthy controls. You can see it here, connectivity, subgenual anterior cingulate cortex, lower compared to healthy controls. In post-treatment of ketamine, you see a decrease in this region. That, of course, has been implicated in depression. The next slide, you see right amygdala, left amygdala, intrinsic connectivity. At baseline here, you see higher connectivity in patients with major depression compared to healthy controls. Ketamine decreases connectivity more towards the healthy control level. So what you see with ketamine is a general reduction in global connectivity with its treatment. Of course, it all has to do with timing, where you measure this. So it's important to obtain drugs that have a more nuanced effect of ketamine so it doesn't knock down so much connectivity. What is suicide? In this case, it's obvious. This photographer obtained with plate photography the precise moment of a woman jumping off a cliff, a building, sorry. And it's a self-injurious act committed with some intent to die. There are about 800,000 suicides worldwide. Every 40 seconds there's a suicide, and the number of suicides now is 44,000 in the United States. There's 200 hospitalizations because of suicide, and about 300 to 400 emergency room visits. Very unfortunate, but does provide us the opportunity to intervene, hopefully to prevent a suicidal act from happening. Now, through clinical observation, there is no drug approved for suicidal ideation. Through our clinical observations, early on, we noticed people with suicidal ideation improved. And here, towards the left, greater scores in suicide thinking. Down here, time in minutes and days. One infusion of ketamine reduces suicide ideation within 40 minutes, lasting a good part of the week. No significant change in control condition. This now was in 70 subjects, probably is now closer to 100 subjects. We see significant decrease within 40 minutes, lasting a good part of the week. And of course, this has the potential to revolutionize the management of suicide. How so? Well, you may prevent hospitalization. You may be able to get an individual from the emergency room back to their family and to providers and to take good care of them. Give them that time. Now, this is a case vignette of Jane, 59-year-old, disabled, divorced. In yellow, in bold is all the risk factors: alcohol dependence, multiple suicide attempts, sister hanged herself, lived alone with a cat, and she had been having thoughts of killing herself by shooting herself with a gun. Received ketamine within 1 hour, stayed well for a good part of the week. An example of an individual patient. In the last, several slides or so, one area we're interested in is in wakefulness. It has been reported through epidemiological studies that suicide rates are greatest between 12 midnight and 4 a.m. We decided to look at it more systematically, polysomnography. This is each line represents an individual, the time they're awake. You can see how exhausting if this were you. Towards the right, we see healthy controls. Very little time awake during the 12 to 4 a.m. What about patients who have suicidal ideation all over the place? Much more than individuals without suicidal ideation. Now, when you look at this group specifically, you see the following day of treatment with ketamine, what happens. You see the non-responders to ketamine show the same pattern we were seeing. Look what happens to the pattern of sleep and wakefulness in individuals who had a response. It looks like it's normalized in these individuals. Now, as I mentioned earlier, we're using sleep deprivation, which has been demonstrated to produce rapid antidepressant effects lasting until you go to bedtime, but has not really been systematically looked at in terms of its effect on suicidal ideation. And let's focus on this risk period where studies suggest there's a 4 times greater risk of suicide attempt. One individual patient received sleep deprivation, and we expect an improvement in depression, but what about these other components? Look what happens to suicide ideation when they're sleep deprived. Significant increase in thinking precisely between the midnight and 4 a.m., suggesting there's something here that we need to follow up with. Sadness goes down here, as well as pessimism. Intention goes down very early on. So perhaps we can learn more from this. And for that reason, we have developed a neurobiology suicide protocol, which its main goal is to study patients who recently attempted suicide or currently have suicidal thinking. Most of the previous studies have studied individuals who had a previous attempt, not in the moment. And we think that's going to give us a better sense using this multimodal technology strategies I mentioned on better identifying the neurobiology of the suicide process. Finally, in the last point, is there more to the ketamine story, the ketamine paradigm? And this involves a multi-institutional effort. We've been doing this for quite a bit. University of Maryland, NCATS, NIA, Chapel Hill, North Carolina, and NIMH. What was intriguing is that when we look at this curve of response I mentioned, peaks at day 1, is, the dissociative side effects only last about 40, 80 minutes. The half-life is gone of ketamine and its norketamine, its metabolite, but why do they keep on responding and stay well for a good period of time? Is there something else going on? So we decided to look at the metabolites. Here we have ketamine, metabolized to norketamine, dehydronorketamine, and there's hydroxynorketamine and hydroxyketamine, a bunch of them. And so if you look at our patients, some are associated with treatment response, some are with non-response, and some do not associate with the dissociative side effect. And in fact, interesting, some of the metabolites stay around for at least 3 days, if not longer. So is there something going on here? So this is going to be only part of the story. Some of the metabolites are not NMDA antagonists. BDF is presumed to be important to ketamine's antidepressant properties. But unfortunately, because this is a multi-institutional effort, I'm not available to present the results, but except to say we have selected a candidate drug. We are going to be starting toxicology studies soon, and hopefully we think we will pass the toxicology studies. Since these are metabolites, have already been in humans, we will be able to conduct phase 1 and 2 studies at NIH. To wrap up, we are gaining knowledge on multiple levels at the molecular cellular level, where preclinical insights are fueling clinical studies are fueling preclinical. There's this back and forth clinical translational research is going. At the system circuit level, our proof of concept studies are integrated with biological biomarker studies, and that is informing us of, these are initial results of the neurobiology of the response process, and soon, hopefully, the relapse process. At the human level, we are trying to obtain biologically enriched group and test that biomarker prospectively by randomizing patients based on the biomarker. We believe, and hopefully this approach leads to more rapid and better treatments for our patients. I'd like to acknowledge everybody that has participated, many people. Allison Eugen, which is our physicist, and does the imaging. Larry Park does all the clinical treatment. All our fellows, I'd like to acknowledge Nancy Boucher, who has been from the first infusion to the most recent infusion, our nurse in charge of the ketamine studies. Razvan Emily, who does all the diagnostic, many of the diagnostic training, rating skills, keeps our clinicians finely tuned. And of course, the wonderful staff on our 7 Southeast, all our nurses, take very good care of our patients and also our research. But most of all, I'd like to thank many other people, and none of this would have not gotten done without our patients and their fans. So I'd like to stop there and thank you for your attention. You have time? Yeah, sure.
Okay, well, thank you, Dr. Zarate. That was special. We have time for a few questions, and then after the questions, we will have a reception for anybody who would like to join in the library with a little bit of nourishment provided by FAS. So please use the microphones for some questions. Yes, thank you.
Well, congratulations for looking at the effect of ketamine on this bipolar disorder and other patients. After administering the ketamine, do the sleep effect occurs at night in the window you mentioned when they stay awake between 12 to 3 o'clock or 3:30?
So the question again, does the sleep normalize?
Yes.
Well, at least in a subgroup of people, it seems to. And what I showed here is individuals who seem to have a response to suicidal ideation. Now, why are they awake? Are they having this internal rumination? They want to die and die. But in fact, most of the time is doctor visits, are usually done on a monthly basis. You ask your patients, well, where you're sleeping, and we really don't pin down if it was at a specific time at night. And so this suggests in this very early work that we had to pay more attention. So it doesn't normalize in everybody, but it would be important to identify in those who it normalizes versus those who does not.
You also did all the imaging studies. I was wondering, is there a variation of the diurnal or different or nocturnal images that changes might occur in the imaging signals in different parts of the
We have
brain?
not done imaging throughout the day. They're very timed with the drug effects at this time. Okay.
Thank you.
Just a comment at the beginning. You stressed that the suicide was constant. And I'd just like to say, I said this before in another suicide conference, but that the incidence of suicide is quite a questionable diagnosis. It's made by medical examiners or coroners, and certainly without the same precision as troponin and myocardial infarction. And I think this has to be acknowledged. And I think with the trend and increase of drug abuse and drug overdose, there's probably a lot of medical examiners with a strong bias towards calling them suicides, which may lead to an artifactual bump in what you might call suicides, but might in fact be drug overdose.
Well, right. I mean, you are bringing up we don't have a reliable biomarker to measure that. We rely on patients telling us what's found in autopsy, unfortunately. Here, what we're trying to do is our patients are in patient settings. Still, it's self-report, but we are able, I think, to have a better handle to better describe on what the suicide process might be, and we go a lot of the detail. Now, how to translate our findings into the community is another story, but you are correct that many attempts are missed, perhaps.
Okay, I want to give this gentleman a chance. Thank you.
Thank you. Congratulations, Carlos, to you and the other pioneers who are really bringing forward the first new treatment for depression in decades. So there's another new wave of treatment which involves drugs with dissociative effects, and this is the use by Roland Griffiths and also some researchers in England of psychedelic drugs, yes, actually, including psilocybin in the treatment of PTSD and also in the depression that can accompany end-of-life preparation. And they're reporting some pretty remarkable results with these drugs that may disrupt default network. So you're emphasizing that the ketamine's effect really may not be through the dissociation, but do you see any parallels to the effect of ketamine with the effects of these other drugs that
and so
that are
we
dissociative?
have, and that's an interesting question, and there's a very nice review in Nature Neuroscience about these psychedelic drugs and perhaps their role in psychiatric disorders. And so ketamine does produce at certain doses cognitive effects, which is interesting. Scopolamine has antidepressive effects, does produce cognitive effects. These other drugs do produce cognitive effects. Is there a common link? But that is now. Remember, some of these drugs were used in the past with psychotherapy, psychoanalysis, and they reported improvement. But of course, for restrictions, its use was stopped, and we didn't have many of the tools and technologies that we have today. So we can get a better sense: what are the circuits turn off with these drugs? How connectivity is increased or decreased, and what parts of the brain it is. And so, now some people are doing these studies, and there haven't been many larger replicated studies yet, and it's a very difficult area of research for obvious reasons. I think it's a fascinating area. Now, some of these drugs are quite toxic, as you know, and some of these drugs, some of these patients may even have, re-experiencing flashbacks of their experience, and so there are many unknowns of these drugs. But I do think, it does deserve a second look at, and to see what role they may or if not have. And they're also used in hospice care and pain management and so on and so forth. Thanks.
Thank you, Carlos.
Well, thank you very much, and please join us for the reception across the hall.
Thank you.